All right, so no disclosures. So why do we need novel therapies? Basically, novel therapies we need because we have a therapeutic ceiling with our therapies. Currently, clinical response rates seem to be no higher than 60% with currently available treatments. In our clinical trials, we want to see higher clinical response, higher endoscopic remission, more corticosteroid-free clinical remission as well. And we're also seeing loss of treatment response over time. So especially with our anti-TNF therapies, up to 30% of patients can lose response to their treatments, like in this particular case. Immunogenicity is a main concern. So we want therapies that won't stop working over time and will work even as second-line therapy as well as they would as a first-line therapy. We also have challenging phenotypes, so this is what's going on in this patient. So we have perianal Crohn's disease, and we also have stricturing disease, which is very refractory to our current mechanisms of action for therapy. So we need novel mechanisms of action to be able to treat this, or possibly novel targets to be able to address it. Lastly, we always want to be finding safer therapies, and that's going to be always an objective for us. So when I think of novel therapies, especially for Crohn's disease, it's not just about different mechanisms of action. It's also about strategy. So I'm going to talk briefly about all these different ideas, novel strategies, novel mechanisms of action, novel routes of administration that are available now, and novel targets of therapy. So let's talk a little bit about novel strategies. So if we have a therapeutic ceiling with one biologic, what if we combine them? So there's more therapies, more studies now that are looking to see if we can combine biologic treatments. So this is the Explorer study, was published last year in Clinical Gastro or Hepatology, and it's more of a proof of concept. It's not a randomized control trial, but it's a phase 4 open-label study of vedolizumab, adalimumab, and methotrexate combination therapy in Crohn's disease. So this is for biologic-naive patients with newly diagnosed moderate to high-risk Crohn's. It was 55 patients, and they received combo IV vedolizumab, sub-Q adalimumab, and oral methotrexate. So the adalimumab was continued until week 26, methotrexate until week 34, and then vedolizumab continued on to week 102. And the primary endpoint was endoscopic remission at week 26. And this was at 34.5% for endoscopic remission, and secondary endpoint was clinical remission at week 26, and it was 54.5%. So they did a post-hoc Bayesian analysis. So the probability that triple combination therapy produces higher endoscopic remission than benchmark rates for vedolizumab monotherapy was 86.3% and 71.4% for adalimumab monotherapy. So the thought is that by combining these biologics, we're actually achieving higher endoscopic remission than if we had monotherapy alone. And we're going to be seeing more trials like this right now. The CD Duet study is ongoing, which is combining guselkumab with golimumab. So that's looking at an anti-IL-23 and an anti-TNF agent in combination. We're seeing studies from the ulcerative colitis that actually look pretty promising and raising our endoscopic remission rates. So another important strategy is, well, we have to think about how can we decrease immunogenicity. This is incredibly relevant for anti-TNF therapies, as we saw with our patient that we talked about earlier. So this is, not the hottest off the press data, but I think it's important that we talk about. So this is, there was a study from the PANTS trial from the UK, and they found that patients that were on anti-TNF therapy in combination with immunomodulator had lower risks of immunogenicity than if they were without an immunomodulator. And they had a genetic risk allele called the HLA-DQ-A105 allele. And they found that patients who have this risk allele have a higher risk of immunogenicity and losing response to therapy than those that don't have it. So in patients that are on infliximab without an immunomodulator with this risk allele, 92% chance of developing antibodies at 1 year. That's really high. Adalimumab with an immunomodulator without that gene risk allele, 10% chance of antibodies at 1 year. So should we be checking this gene risk allele early on before we start patients with anti-TNF therapies? Because maybe their pharmacokinetics are unfavorable towards anti-TNF, and they should be thinking about other biological therapies first, or if they're on an anti-TNF, they should be in combination with an immunomodulator. So there are abilities to test this now, so I think it's something we may be thinking about. Yesterday, I talked a little bit about considering ileocecal resection for Crohn's. So I'm not going to go into too much detail, but basically patients that had early ileocecal resection versus anti-TNF therapy had lower long-term adverse outcomes than having anti-TNF therapy up front. And 50% of patients in the ileocecal resection group had no treatment at 5 years. So there may be a subpopulation of patients that really do well with upfront surgical treatment, especially have limited disease. And perhaps, we should be thinking more about surgically induced remissions early on on instead of cycling through multiple biologics afterwards. So something to think about now, and we need more data, though, for this. So let's talk about novel mechanisms of action. Our therapeutic landscape for Crohn's has really changed. We had only infliximab, then other anti-TNF therapies that were later available, then now new novel mechanisms of action with vedolizumab and ustekinumab, and most recently, we have risankizumab that was approved in 2022 and upadacitinib in 2023. So let's go and talk a little bit about the anti-IL-23 agents. So ustekinumab block P40 subunit, so that blocks both IL-12 and IL-23, but the newer anti-IL-23 agents block the P19 subunit. Why do we even bother doing this? So there's some studies that suggest that selective IL-12 inhibition does not work. And then animal studies suggest that selective IL-23 potentially could be better than combined inhibition of IL-12 and IL-23. And there's some positive results seen with IL-23 selective inhibition for psoriasis. So that's why this has been really, hot, and a lot of, everyone's been chasing after this. So these are the different anti-IL-23 agents currently available or under late development. So I'm going to focus on risankizumab. It was approved for Crohn's disease in June of 2022. The induction dose is 600 milligrams IV infused over 1 hour at 0, 4, and 8 weeks. And for maintenance for Crohn's, the doses are 360 milligrams sub-Q or 180 milligrams sub-Q starting at week 12 and then every 8 weeks thereafter. Other approved indications include plaque psoriasis and psoriatic arthritis. So in the phase 3 studies for moderate to severe Crohn's disease, the induction and maintenance trials, there were 2 induction trials, 12-week induction trials, so ADVANCE and MOTIVATE. So the ADVANCE had a mixed population, 42% were bio-naive, MOTIVATE were bio-failure patients, and they were randomized to 3 different arms, risankizumab 1,200 milligrams IV, 600 milligrams IV or placebo, dosed every 4 weeks until week 12. And what's really exciting is that FDA has moved away from just looking at clinical remission. So there's co-primary endpoints that are now necessary. So the co-primary endpoint at week 12 was clinical remission, a CDAI score of less than 150, and endoscopic response. So greater than 50% decrease in the SES-CD score from baseline. So those that responded at week 12 went on to have randomization, again, to 3 different arms of risankizumab. So 360 milligrams dosed week 12, and then every 8 weeks thereafter, 180 milligrams week 12, every 8 weeks, or placebo. And they received, in the FORTIFY trial, 52-week maintenance phase, they received these therapies. And this was a mixed population as well, 30% bio-naive, again, co-primary endpoint by the end of week 64. Now, the 600 milligram IV dosing for risankizumab has gone on to development, but not the 1,200 milligram. So when you look at the population, overall, it's a very moderate to severe population when you look at CDAI scores, SES-CD, and when you look at the corticosteroid use, about a third of the patients were on steroid use going into the study, and about a quarter of the patients were on concomitant immunomodulator therapy. And then when you look at the biofailure population, about 50% of the patients had greater than 2 exposures to greater than 2 biologics. So this is a pretty refractory group of patients. And I always like to focus on seeing that subgroup analysis of patients that had been on bio-naive or had previous bio experience, because I think this is where we want to see how our therapies are distinguished from the other ones that we've had earlier. So here with endoscopic response and clinical remission in our induction phases and induction studies, you do see that in patients that receive 600 milligrams of risankizumab versus placebo, that even in the biologic exposed patients, there's still a pretty robust endoscopic response and clinical remission. I really focus on looking at that endoscopic endpoint here, and so even in the biofailure population in the MOTIVATE trial, you do see that significant difference between the treatment group versus the placebo. And then when you look at the maintenance trial, FORTIFY, so you see that both the 360 milligram and the 180 milligram dosing, we're seeing significant differences in endoscopic response and clinical remission versus placebo. And, when you look at endoscopic remission, you do see a slight advantage over the 360 milligram dose versus the 180 milligram dose. I typically stick with the higher doses for my patients, especially since a lot of them have had many previous biologic failures. So another important factor is how fast do these therapies work. So this was a study that looked at early symptomatic improvement with risankizumab, and there were higher rates of stool frequency and abdominal pain score clinical remission as early as 1 week after dosing for risankizumab versus placebo. So I think that's important to share with your patients. This is when we should be expecting some treatment, some symptomatic improvement. And when we look at adverse events, actually this is a pretty safe therapy. When we looked at the pooled induction adverse events, it's actually higher in the serious adverse events was higher in the placebo group than in the treatment arm. And then when you look at all the other adverse event profile, it's actually pretty similar between treatment group versus the placebo in both the induction and in both doses of the maintenance arm. There was one case of a hypersensitivity reaction in the induction study that led to elevated liver enzymes. So it's recommended to check liver enzymes during induction. So what happens with patients that had previous ustekinumab exposure? How well does risankizumab work? This is a question that I have all the time. Is it worth it to switch therapy? So like, for example, in our patient, was it, should we be considering risankizumab in her? So this is a very small post hoc analysis. So we do need more studies to look into this from the Advance, Motivate, and Fortify trial and patients that had previous ustekinumab failure. You do still see some clinical benefit, clinical remission, endoscopic response in this population who've had dosing with the risankizumab versus placebo. So there could be potentially an improvement there. I think that we have other studies that are head-to-head clinical trials looking at ustekinumab versus risankizumab. That's a slightly different question. So there's also the VIVID trial that just came out too that looked into the combination of mirikizumab versus ustekinumab. But I think we do need larger studies to see if there's any added benefit in patients that have had previous ustekinumab failure. So notable features of risankizumab, here are the dosings for it, induction and maintenance, FDA approved for plaque psoriasis and psoriatic arthritis, FDA approved, relatively strong efficacy in both anti-TNF naive and anti-TNF exposed subjects. It has a low immunogenicity, so our newer biologics seem to be doing better with that. Adverse event profile seems pretty similar to placebo. There doesn't seem to be any dose-dependent safety considerations. As I mentioned, check liver enzymes prior to initiating and monitor through induction. The most common adverse events reported upper respiratory tract infection, headache, and arthralgia. And in a meta-analysis of risankizumab studies in psoriasis, which included 7,900 roughly cumulative person years of risankizumab with the treatment duration up to 5.9 years, actually very favorable safety profile compared to placebo. Pregnancy, there's limited data. Dr. Bonthal will talk a little bit about that, but generally biologics are considered to be safe. So I think risankizumab is a wonderful new addition to our treatment armamentarium, relatively safe, low immunogenicity, pretty good safety efficacy in patients that have had anti-TNF exposure. So let's talk about JAK inhibitors. So what is a JAK? So it's an intracellular non-receptor tyrosine kinase that's important for cellular signaling, and it's important. There are 4 different members of this class. So there's JAK1, 2, 3, and TYK2. And depending on which combinations of JAKs are inhibited, you can have different functions. So you can have different pro-inflammatory pathways that are inhibited. So when we look at different JAKs right now in development, they target slightly different receptors. So tofacitinib is approved for ulcerative colitis, and it targets JAK1, JAK3. Upadacitinib is a selective JAK1 inhibitor and currently approved for UC and Crohn's disease. And there are currently other JAKs that are in development right now. So I'm going to focus on upadacitinib in Crohn's disease. It was approved in May of 2023. Induction doses for Crohn's is a little bit different than for ulcerative colitis. It's 12 weeks of 45 milligrams as opposed to 8 weeks in ulcerative colitis. Maintenance doses are 30 milligrams daily or 50 milligrams once daily. It's also approved for a lot of other conditions: ankylosing spondylitis, rheumatoid arthritis, psoriatic arthritis, juvenile arthritis, and atopic dermatitis. So if you have patients that have overlap with other conditions, this actually could be a wonderful treatment option. So let's talk a little bit about the phase 3 data for moderate to severe Crohn's disease in the induction and maintenance trials. We had UXL and UXceed, which were the 2 12-week induction studies. The UXL had a mixed population, roughly 40%, 45%, but with biologic failures. And then the UXceed was only a biofailure population, and patients were randomized in a 2-to-1 fashion to upadacitinib 45 milligrams versus placebo for 12 weeks, re-randomized if they were induction responders, and went on to the maintenance study called the U-Endure study. And in that study, this was a mixed population, and patients were randomized to upadacitinib 30 milligrams daily, 15 milligrams daily, or placebo. Again, co-primary endpoints here, including clinical remission, a CDAI score less than 150, and endoscopic response. Very important that these endoscopic parameters are here. So let's look at the patient population. Overall, about 35 to 37% were on baseline steroids. And we look at prior biofailure, about in the mixed population group, about 46% had prior biofailure. And in the biofailure group, in the UCLA group study, about a third of patients had more than 3 prior biofailure. So this was a pretty refractory treatment population. So I want to draw your attention to the, again, that box here, and that's comparing patients that had prior biofailure versus patients who are bio-naive. And you can see when you look at clinical remission and endoscopic response, there's pretty nice treatment difference between those that have, even those that had prior biofailure. And it's not that different from patients that had no biologic exposure at all. So I find this very promising in patients that have had previous biologic failure as a second-line treatment. And Dr. Singh will talk about this a little bit later. And then when we look at the week 52 data, when we look at biofailure versus bio-naive, I think it's interesting here that the 30 milligram dosing arm really does seem to stand out in patients that had previous biological failure. It seems pretty equivalent at 15 and 30 if you're biologic naive. So I usually use the 30 milligram dosing for my patients, as most of them have had previous biologic failure. Okay, so what about upadacitinib for fistulizing disease? I think these data are incredibly promising, still in abstract form. In the UXL and the UXC trial, 143 patients had fistulas, so 87% with perianal disease, and then 13% with enterocutaneous fistulas. 54% had perianal fissures. So they looked at outcomes at week 12 and week 52 of external closure of fistula openings, complete resolution of draining, greater than or equal to 50% reduction in draining, and complete resolution of fissures. When we look at all these outcomes at week 12, they're statistically significantly different in patients that were on upadacitinib versus placebo. And at week 52, again, patients dropped out, so not as many patients that were being followed at that time, but there's still significant difference at both doses with the external closure of fistula openings versus placebo, and in complete resolution of fissures. So I think this is something we're going to hopefully see more on, and we do need to see more trials that look into perianal fistula healing with our therapies. When we look at adverse events, overall, pretty comparable between the placebo and the treatment arms in both the pooled induction and in both doses for the maintenance. What I do want to draw your attention to is, though, this is pretty much a class effect with JAK inhibitors. There is a higher risk of shingles that we say, of herpes zoster. So in all my patients who I'm committing to upadacitinib or tofacitinib for that matter, I do think that it's important they have a Shingrix vaccine. So I try to get them that first dose of Shingrix before they go on to get the dosing of upadacitinib, just because it seems to be kind of hard to get, and I want to make sure that they commit to this. So it's important that we get that vaccine in. So notable features for JAK inhibitors, these are the induction and maintenance doses, again, 12 weeks for Crohn's disease. Rapid onset of action, so studies in ulcerative colitis show that there could be significant differences in symptoms as soon as day 1. So it's pretty amazing. Comparable efficacy, as we saw in anti-TNF exposed and anti-TNF naive patients, and it can address extraintestinal manifestations, including arthralgias, axial arthropathies, and there's possible benefit with perianal fistula. So this is really exciting. Safety considerations overall look pretty good. Infection malignancy rates are mostly similar to placebo. Herpes zoster rates are higher than placebo, so we think, again, important to get the Shingrix vaccine. Slightly higher LDL and HDL we see with these therapies over time, potentially 20 to 30% increase. Also, we do see a lot of acne. About 7% of patients can develop some acne. It really responds great to topical Clinda. Some of my derm colleagues call it Jackne as a result. So it's just something that we do see. Increased thrombosis risk in patients have been seen with this class of medications in the oral surveillance study in rheumatoid arthritis over the patients who are over age 50 with cardiac comorbidity. This was noted in another JAK inhibitor versus anti-TNF. So therefore, JAK inhibitors are positioned after TNF biofailure or intolerant patients. So let's talk about novel routes of administration. Sub-Q infliximab is going to be available anytime now if it's not quite yet. It's FDA approved in October 20th, and it is CTP13. It's for the maintenance of ulcerative colitis and Crohn's disease, and is based on the Liberty trials. And CTP13 is a biosimilar of Remicade, and it's approved in Europe since 2020. So basically, after 3 intravenous doses of infliximab at week 10, you switch to sub-Q 120 milligrams every 2 weeks. So in the Liberty trials, what they did was they had IV induction doses at week 0, 2, and 6. And if there was clinical response with the 100-point reduction in CDAI by week 10, this was considered clinical response, so they were randomized to CTP 13 or placebo. And the co-primary endpoint here was clinical remission and endoscopic response at week 54. And you do see here, when you look at the co-primary endpoints, it's significantly different and higher in patients that had the CTP 13 than placebo. And again, you see the key secondary endpoints are all significantly improved on the CTP 13. So pharmacokinetics are really interesting for sub-Q dosing. When we think about IV versus sub-Q, so IV, we see peaks and troughs, high peaks, low troughs. And typically for IV dosing, we check a trough level, and we've been matching that to treatment efficacy, right? So pharmacokinetic properties that predict efficacy, still not clear though. It's going to be different for sub-Q. So we look at total drug exposure. We can be looking at maintenance of drug stability. We can look at peak levels or trough levels. So for sub-Q formulations, we're seeing lower peak concentrations. We're seeing higher trough concentrations and smaller differences between the peak and trough. But overall, the thought process is that with the sub-Q dosing, the total drug concentration is likely similar between IV and sub-Q dosing, even if the actual pharmacokinetics is a little bit different. So this is quite challenging. So the thing is, the numbers that we're used to seeing for IV for the levels might be different in sub-Q, and we're trying to understand what targets we should be looking at. So this is an important study. It's called the REM switch study. So they looked at the rates of relapse after switching from IV to sub-Q infliximab. This is a multi-center cohort study for patients in remission after IV induction and then on sub-Q 120 milligrams every 2 weeks, and included 133 patients in clinical remission. And what I like about this study is that they included patients with dose-intensified infliximab. Are these patients going to be doing just as well? So the objective was clinical and pharmacological outcomes after switch from IV to sub-Q up to 24 weeks. What they found was 67% of patients on 10 mg per kg every 4 weeks relapsed, and trough drug levels did not increase after switching. So predictors of disease relapse after switch were patients were on that dose-intensified 10 mg per kg every 4 weeks, those that had high calprotectin at the time of the switch, or patients that did not have an increase in their drug level between baseline and that first visit 4 to 8 weeks out. So we expect to see with the sub-Q change that there should be an increase in the drug levels, actually. And so those that did not have that had higher risk of relapse. And then in the long-term study, so they looked up to 18 months, we're seeing similar trends, that factors associated with relapse were with the dose-intensified strategy. So those with 10 mg per kg every 4 weeks had a higher risk of relapse here than the lower dosing. 10 mg per kg every 6 weeks, okay, but you're still seeing some increase in relapse in that group as well. And those with decreased or stable infliximab levels after the switch had a higher risk of relapse. But in those that had a relapse, if they were increased dosing to 240 every other week, they were able to recapture response. Here are 82% of patients. So the proposed algorithm that the authors came up with for switching from IV to sub-Q is this: a patient in clinical remission, yes, go on. Calprotectin level in less than 250, yes, good. Last IV infliximab regimen. If it's 10 mg per kg every 4 weeks, either don't switch or consider a higher dose to switch, 240 every other week. And then if they're on 5 mg per kg every 8, 10 mg per kg every 8, or 10 mg per kg every 6, you can still do the 120 every other week, but check an infliximab level. And if it's not higher than where you were before, then consider therapeutic escalation to 240 every other week. So I think this is going to be really interesting. And there's some even questions whether sub-Q dosing could potentially decrease the immunogenicity of the drug. It'll be really interesting to see. So last, I'm going to talk about novel targets of therapy. This is not available in the US, but it is approved in other countries. This is, and our patient actually had this. So stem cell injection for perianal Crohn's disease. So this is looking at allogeneic expanded adipose-derived stem cells. So for perianal Crohn's, and this is a randomized double-blind placebo-controlled study to determine the long-term efficacy and safety of a single local administration of this allogeneic expanded adipose-derived stem cells in patients with Crohn's disease and perianal fistulas. And they looked at the endpoint of combined remission. So it was a more rigorous endpoint of closure of all external fistulas, absence of any collections by MRI, and clinical remission. And they do see significant differences in that combined remission at both week 24 versus standard of care and at week 52. So you might be seeing more of this, and I like the fact that we're looking for novel targets for this really refractory condition. Okay, so our take-home points: there are limitations to our current treatments, novel strategies we need to think about, especially for Crohn's. It's not just about new mechanisms of action. We have to think differently about how we treat Crohn's. And then new mechanisms of action are available that I think some of them are pretty awesome in terms of their low immunogenicity, relatively strong treatment effect after anti-TNF. Novel routes of administration available. Maybe think twice if the patient's on 10Q4, a treatment escalation if you're going to do sub-Q dosing. And then novel targets. Direct administration of stem cells into perianal fistulas might be an interesting solution for the future. So now that we know all about all the treatments for Crohn's and the new therapies, I'm going to move on to Dr. Singh, and he's going to talk about how we position these therapies in Crohn's disease.